Well, hello, everyone. Good afternoon or good morning, depending on where you're joining us from. My name is Stacy Chazen, and it's my pleasure to welcome you to today's Veteran Oral Health Action Collaborative. I am the Director of Education and Leadership for the American Institute of Dental Public Health, and it's my pleasure to be facilitating for you today on behalf of AIDPH and CareQuest Institute for Oral Health. So we're going to get started. I know a few people are still flying in through cyberspace, but we're going to get going with some of our housekeeping items. I'm going to begin sharing my screen. So today's Veteran Oral Health Action Collaborative call is titled Public-Private Referrals for Veteran Oral Health in the Community Care Network. Some brief housekeeping items. Today's call is being recorded, and the recording link is going to be shared on AIDPH's website following today's call. As with all of our VOHAC calls, today's gathering will include both formal presentations and interactive learning. We like to emphasize the latter. So we'll be turning to you with some specific questions, but also invite you to chime in with questions as we go along in the chat box. And then we'll also have some time for Q&A following the formal presentation. If you have not already done so, we encourage you to add your personal pronouns to your Zoom screen name. And we ask that you stay muted until you're ready to speak, but ask that everyone do keep their cameras on if possible to increase the extent that we can all feel connected and engage with one another. So giving you a brief overview, the CareQuest Institute for Oral Health and this program focuses on being a catalyst for systems change through its areas of activation and influence. CareQuest brings forth ideas and solutions to create a more accessible, equitable, and integrated health system for everyone. CareQuest's Medical Oral Expanded Care or More Care program, if you don't know about it, aims to address health disparities through integration of oral health in primary care practice and the development of dependable oral health care networks. Using an improvement-based framework, partners work with key stakeholders in their communities and abroad to create a usable model of interprofessional oral health care. More Care serves to advance the integration of care and the coordination of care, and we encourage you to visit CareQuest's website to learn more about that program. About AIDPH, we are a 501c3 nonprofit organization with the vision of an equity-oriented oral health workforce that is prepared to lead. AIDPH fosters professional excellence and advances innovation in the education and practice of dental public health. And we do this by focusing on 4 key communities: rural residents, veterans, LGBTQIA plus individuals, and individuals with disabilities. So, the Veteran Oral Health Action Collaborative. For those of you who are new here or need a refresher on what we are, VOHAC is a framework for both learning and action. So not your typical learning collaborative where we share ideas and frameworks with you, but really focus on how you can operationalize what you're taking from these calls. The program includes monthly seminars, interactive applied learning, which are incorporated into the seminars, and follow-up materials. We offer a certificate through this program. When you complete sessions, you have the opportunity to complete competency evaluations, and you also have the opportunity to earn continuing education credits for each session that you attend. And we'll share some more details on that later in today's call. Improving veteran oral health through integration is the focus of this effort, including shared responsibility for oral systemic connection, a referral network of providers, transitioning care models, an environment of improvement, and the optimal use of health information technology. And we're hoping that by participation in this program, your outcomes will be increased knowledge and capability to apply integrated and value-based care concepts in your clinical environment, that you'll get a tailored education and application plan that benefits individuals and their organizations who are taking part, improved quality of care for veterans as a result of your work, and a peer network that you can rely on for ongoing conversation and connection beyond the life of VOHAC specifically. As I shared, you have the opportunity to complete an evaluation after each session to earn free CEUs. We'll be posting a link to that survey at the end of today's call. And if you successfully complete competency quizzes for 6 sessions, either those you watch live or recorded, you can earn a certificate in integrated care approaches to veteran oral health. Organizations with 2 or more individuals earning that certificate will be awarded with a certificate of commitment to excellence in veteran oral health. So it's my pleasure now to introduce our 2 speakers on today's call. We're first going to hear from Dr. McAllister Castellez. McAllister is a general dentist and dental public health graduate student with experience providing dental care in FQHCs. She received her doctorate in dental medicine in 2017 from Boston University, Henry M. Goldman School of Dental Medicine, and then did a 1-year general practice residency at Lancaster General Hospital. From there, she practiced full-time in community health centers in Wisconsin and Virginia, serving as lead dentist and dental director. She's currently completing a master's in dental health at the University of Iowa. McAllister is an active advocate for alternative models of care, including mobile and teledentistry. Her current areas of interest include dental workforce, access to care solutions, veterans, and value-based care. And with that, McAllister, I'm going to turn it over to you, and we're going to introduce Christine later on in the call before we hear from her. So I'm going to stop my share and hand it over to you to share your screen.
Okay. Thank you very much, Stacy, for that lovely introduction. I'm going to go ahead and share my screen, which will be this one here. Share. Can everyone see the learning objectives right there? Yeah. All right.
Yes.
Fabulous. Okay, good. Making sure I'm hitting all the right buttons. All right. So for the first part of this presentation, as Stacy said, we'll begin with the didactic portion, and then my colleague Christine, who we'll meet very soon, is going to present a case for all of us to discuss. But as part of this presentation, we have 3 learning objectives for everyone. First, we want everyone to be able to apply integrated care principles to help improve oral health of veterans. We're going to talk about how we assess the role of the VA's community care network in providing oral health services to our veterans. And then finally, identify potential applications of telehealth and veteran oral health as supported by the VA's community care network. So just to give everyone kind of a little bit of an idea, I like to just level set with the state of our veterans dental care. We do know that this is a very underserved population. About 42% of our veterans do report having some sort of gum treatment or bone loss happening around their teeth. 2 in 5 veterans describe their oral health as fair to poor. And in 2020, over 24,000 veterans had visited the VA emergency department, so not our community clinics, but the VA specifically emergency department for non-traumatic dental conditions. For those of you who are not as familiar with why this can be problematic, is unfortunately a lot of the times our emergency departments are ill-equipped to deal with non-traumatic dental conditions, and very rarely do individuals who visit the ED for these reasons end up getting definitive appropriate treatment to address their dental needs. I do want to highlight that the influences of our veterans' oral health status comes from experiences prior, during, and post their service commitment. So just to kind of give us an idea of that, while we're looking at individuals in one instance, there's a lot of experiences that they had that are going to influence their actual oral health status. We know that a lot of individuals from lower economic statuses are going to be enlisting compared to those who are coming from higher income families. We have seen in other examples in our literature that low income status is often a risk factor associated with poor oral health status. Once they're enlisted, there is this culture of smoking and energy drink consumption that's very prominent in the military. One of my co-residents is in the Air Force, and that's one thing that we'll talk very frequently. Not so much that he's noticed that for a lot of the enlisted that he sees smoking in the younger generation, but it's this big energy drink consumption, and the acid and the other non-protective factors that are going to start happening really not supporting positive oral health for our veterans. And then additionally, for those who are deployed to those more remote locations, often will have limited access to preventive resources. So having the appropriate toothbrush, toothpaste, clean water to use to brush their teeth, as well as access to comprehensive dental care. Sometimes they need to fly the dentist out to the base to address the dental needs. So it's not something that's happening very regularly for these individuals when they're deployed in those more remote locations. And then finally, the resources that are available to individuals while they're enlisted often may disappear once they separate from their military service, and those resources cease to be available. They have dental care while they're enlisted. Well, once they separate, they might not have access to the same level of care, which we'll kind of get into. I do want to also highlight that with our veteran population too, actually, let's go to the next slide before we talk about that. Sorry, everyone. And as I was saying, as we talk about individuals once they separate, we do see that millions of Americans, including our veterans, are having difficulty accessing dental care. We know that about 15% of our veterans are eligible for dental care through the VA healthcare system. This is because those dental services must be service related if they're going to get care through the VA healthcare. So only about 15% of our veterans are actually able to access care in the VA. And then on top of that 15% that are accessing care, only about 34% are actually utilizing services. Which equates to about over 463,000 who are actually getting dental care in the VA healthcare system. In 2018, the Mission Act aimed to help expand the access to healthcare, including dental care for our veterans through the Veterans Affairs Community Care Network. So one way to help address that challenge to access. And we'll get a little bit into what that looks like. However, with that community care network, one thing that we want to keep in the back of our mind is the role that integrated care is going to play, and not just the community care network, but how our veterans are able to access care and manage and achieve positive oral health outcomes. So as we had talked about previously, we do know that many of our veterans already are struggling with oral health disease, gum disease, periodontal disease, dental caries, and they often face more challenges than our civilian population, than those who are of non-veteran status. We do see that amongst our veterans, there's a greater prevalence of self-reported oral health, poor oral health among our veterans. A lot of our veterans tend to originate from groups that are a higher risk for poor oral health outcomes. They're older adults, they're smokers, they are male, they are diabetic, and the prevalence of these adverse oral health conditions are going to be higher among veterans. It's not just the one that they got used to drinking all these energy drinks while they were enlisted. It's a lot of other factors that are coming into play. They have their adverse health behaviors, smoking, energy drink consumption. They have systemic conditions, diabetes, all of these things that we know are risk factors that are contributing to their poor oral health status, in addition to not being able to always navigate the system to access the care that they need. So that being said, where veterans are then starting to look is FQHCs for care. So FQHCs, or federally qualified health centers, are government-funded facilities that serve low-income individuals in our underserved communities. We saw that in 2017, about 355,000 veterans had reported seeing some, or we got a report from the UDS saying that that number of veterans had received healthcare in an FQHC. In 2021, that number had increased to over 388,000 veterans. Veterans comprise about 1.3% of the patient population that's seen by FQHCs across our country. Do you want to highlight when we're talking about veterans accessing care in an FQHC? This is referring to any sort of service that is happening that the FQHC does offer, so not just dental, but any healthcare service. And I have a breakdown of that in just a few slides. The reason why this is important is our FQHCs are leaders in integrated and patient-centered care. Health centers have to comply with very specific health center program requirements, as well as other federal and state requirements. What those actually look like, I've highlighted on the slide here. So first and foremost, our FQHCs, they're going to be community-based and patient-directed, meaning that they are aiming to address the needs of their community and the patients that they are serving within their own community. They have a charge to provide comprehensive, high-quality primary care and preventive services, regardless of that patient's ability to pay. For those of you who do work in FQHCs, we often know this means putting them on if they're eligible for a sliding fee schedule, So being able to discount services, but even if they still can't make those payments on that sliding fee, they can receive care at the FQHC. Many FQHCs, because we have multiple healthcare professionals working, there's this opportunity to employ interprofessional teams that allow us to take that more patient-centric approach. FQHCs really emphasize the use of care coordination, other enabling services to help facilitate access to care. So being able to work with, as a dentist, being able to work with my physician colleagues, with my behavioral health colleagues to help understand the full picture of my patient's health, and then also understanding challenges that they might be having with being able to, say, come to the appointment on time. I've been very fortunate where I've had social workers at our FQHCs who can help many of our patients navigate some of those challenges that they face, being able to figure out transportation, making sure that if they are eligible for public insurance, helping them walk through that process and apply and be successfully enrolled in Medicaid programs. And then finally, our FQHCs work to collaborate with other providers and programs outside of their own organization to help promote access to care and community resources, especially those that are going to address the social determinants of health. One of those community resources that we're going to be talking about is the Community Care Network through the VA healthcare system, and the opportunity that FQHCs and our private practice colleagues do have to be able to work with those. So dental services account for about 18% of all the healthcare services provided by FQHCs overall. So not just veterans, but overall FQHCs, as we can see, a vast majority of them, we're talking about medical services. It's about 85% of the services that are provided there. However, dental is at a little over 18%, and that number is increasing over time. We do see FQHCs also have other services such as mental health, other enabling services, vision, substance use disorder. So as I was saying, this is really great opportunity to work with a interdisciplinary team to really deliver quality patient-centric care for our veterans and for anyone who comes to the FQHC for care. So just emphasizing that integrated healthcare is this collaboration among our healthcare professionals to provide complete treatment and improve the overall well-being of our patients. For those of you who have maybe heard of that quadruple aim, that's what we're talking about. We want to be able to deliver quality care that's a positive care experience for our patients, for our teams that are providing the care. We want to have positive health outcomes, and we want to be smart about how we're doing it and be efficient with the funding and make sure that we're saving money while we're doing it. So being able to balance all those components is really part of integrated care as well. So with integrated care, there are a lot of, this piece of literature had highlighted these kind of 10 universal principles across integrated healthcare systems. The authors of this particular study had noted that the principles allow for organizational flexibility and adaptation to their local needs. These aren't intended to dictate some one-size-fits-all model of this is exactly how you're going to do integrated care and you have to check all these boxes in this specific way. But these are more principles that you should be using to guide those goals. So with our comprehensive services, meaning that we have multiple points of access with an emphasis on wellness and health promotion. When we talk about patient focus, looking at our patients' needs and their engagement and their utilization, and then also looking at a population-based level of that needs assessment too. When we think about geographic coverage and rostering, actually maximizing the accessibility while minimizing the duplication of services, meaning that we have opportunities for our communities to access care, but we're not having a lot of the repeats, that we're being efficient with how we're delivering the care and who's delivering care where. Following standardized practices as well, using interprofessional teams. So following evidence-based guidelines and protocols, and then using performance management interventions as well to help us remain committed to quality services with an evaluation and improvement component. So continually looking at our systems to identify ways we can improve. Using information systems to be able to collect, track, and report the activities of our healthcare systems and our FQHCs, and those relationships that we have between the FQHC and our community partners as well. Having an organizational culture and leadership team with a vision, and having physicians really integrated and engaged in not just the clinical care, but the participation and the buy-in of the relationships and the processes that we have in delivering that clinical care. Talking about governance, so making sure that we have a diverse representation of all relevant community stakeholders as well. And finally, I think financial management, so sufficient funding for adequate resources to ensure that the patients are receiving the care that they need, and the staff has the support that they need for training and development as other needs are identified for everyone. So just some facilitators to help our those wanting to really engage with this integrated care approach, making sure, as I said, having well-defined and evidence-based services, using our general practitioners in a collaborative manner, making sure that we have diverse, sustainable funding and other resources too. It's not just our money, but having the time and the resource and the workforce to be able to do all the other administrative work and those other tasks that are going to happen around getting our patient into the chair and having our clinicians be able delivering the care that they need, and then being able to make sure that the patients get the follow-up that they need. So making sure that you have those same shared goals and values and this commitment to that joint work. Electronic communication, we are so fortunate to live in a day and age where we have access to such wonderful technology to really help enhance that, which we'll talk a little bit about soon. And then I said, just again, making sure you're monitoring your quality and your performance as well. And as we start talking about the community care network, making sure that as you look to engage with that between, say, your health center or your practice, making sure that you're evaluating that relationship and figuring out how you are not able to just communicate better, but improve the outcomes for the veterans that are going to be navigating that system as well. So the VA's community care network, to give everyone just a little bit of background, if you're not familiar with it, the goal of this network is it's a direct link between community providers to ensure that our veterans receive timely, high quality care. It allows our private practice dentists to be able to be more involved in integrated care system. We do have 5 regional networks across the United States, and they serve as contract vehicles with the VA to purchase care from community providers. There are third-party administrators involved as well that help with the administration of that actual coverage for the care. Community care networks includes everything from medical to behavioral health to dental. And then we can even talk about complementary and integrative health services as well. And that can be like Native American healing. It can be massage. It's not just what we might think right away when we say, well, medical, dental, eyes, and covers a lot of other things too, which is really cool. So why is this community care network so important? Well, private practice dentists are really lack the infrastructure and the resources to be able to participate in a more fully integrated system with their medical colleagues. A lot of dentists do know the importance of being able to have such communication and know the importance of the relationship between oral health and systemic health, but they have a lot of kind of mixed levels of comfort when it comes to applying some of these principles of oral systemic health to their clinical practice. But being able to identify appropriate clinical partners and being able to establish that bidirectional communication between the VA and our clinicians in our community can help coordinate and support our clinicians being able to deliver healthcare services and improve the health outcomes for our veteran population. The referrals themselves, they have to be, the veteran must be referred to a specific community provider from the VA. And this is typically when the veteran's scope of care, if the veteran, has to occur from the VA to the community care provider. Once the veteran arrives at that location, if there's additional care that's needed beyond the scope of the original referral, the community provider can provide a referral request to the VA for evaluation to determine if coverage for those additional services can be rendered. Reimbursement rates tend to follow our Medicare guidelines. Veterans may have a copayment for a non-service connected condition as well when they receive care from their community providers. And so the veterans actually qualify for the community care network. One of these 6 conditions must be met. Either these are services that the VA is not offering, or they don't have that full service medical facility in the veteran state. There just isn't a VA that's in the veteran state. That veteran's driving more than 40 miles to get to their VA. There might be specific services that the veteran requires that are just not available within the designated access standards. The veteran and the referring clinician at the VA may decide it's in the veteran's best interest to receive the specific care in the community as opposed to the VA. Or the VA has determined that the VA medical service line delivering the specific care veteran requires is not providing the care within the VA's, the clinician that's in the VA is not meeting the standard of the VA's care, therefore they'll turn to the community as an option instead. VA health or VA staff schedule community care appointments for the veterans through the local VA. And some of them do receive some scheduling support through the community care network's third-party administrators. And then the VA does provide customer support to the veterans, while the third-party administrators are providing customer support to the VA staff and the community providers. This is just a little find a VA location. This tool is kind of interesting because it not only shows you VAs, but it will show you other providers and clinics that are participating in the community care network as well. Like I said, though, if that veteran does want to access care through the CCN, they must first be approved to be participating in that network through the VA, though, and they need that referral before they can see that participating provider. So the veteran eligibility and coverage for dental services are determined by the VA. The provider, the community provider, is responsible for all necessary follow-up care for that veteran, and the appointment availability standards must be followed. I bring this up just because we know that emergencies happen. So if the provider has to cancel a veteran's appointment, making sure that they're rescheduled in an appropriate amount of time. If it's an emergency, within 24 hours, if it's an urgent dental care need, within 48 hours, if it's routine care, within the next 30 days. Providers do get to complete a quarterly provider satisfaction survey. So they have this opportunity to give feedback to both the VA and their third-party administrator to understand areas where the network can be enhanced for all the stakeholders. And then the third-party administrators do deliver provider training and resources as well for those participating. So why does this matter to everyone? Well, FQHCs can serve as CCN providers. I do want to highlight that back in 2020, about 18,000 FQHCs were delivery sites in the CCN. And roles that our FQHC plays in the CCN, we're talking about they receive the referrals and the appointment requests. They provide the actual healthcare services, and they send the medical documentation to the VA as well as claims to the third-party administrator. Just to give everyone a little bit of an idea of how that workflow looks. So we have our veterans presenting with an oral health care need that can't be addressed in the VA healthcare system. The VA will then send a referral to the CCN provider through the third-party administrator. That administrator receives and processes the referral. From there, the provider then will receive the appointment request from the VA once that is approved. The VA can then schedule with the provider. Some veterans are able to schedule on their own as well. The actual point of care services will occur. And then once that is done, the provider submits a claim to the third-party administrator for reimbursement, as well as any medical and dental documentation back to the referring VA. So again, really helping support that comprehensive picture of oral health and opportunity for coordination of care. So telehealth can play a really important role in supporting our CCN providers as well. Telehealth can be utilized within Medicare guidelines. Within this, typically we'll see telehealth being used for emergency triage, patient outreach, and patient engagement and oral health coaching. We do know that I was looking through some of the third-party administrators language, and one of those third-party administrators did highlight that telehealth was an option for community care appointments for both initial and follow-up appointments when appropriate for a referred condition. So it can be used as needed along with face-to-face care when some physical evaluation or procedure may be required as well. So there's an opportunity to engage with some other, rather than having to navigate getting in person, because there's often a reason why that veteran's facing some challenges with accessing to care. I just want to highlight that if you do have an FQHC or you're a private practice provider in a group, as you're thinking about implementing telehealth to help support participation in the CCN network, making sure that your staff are well prepared with clear roles and responsibilities. If you have a telehealth program, making sure that you are always reviewing licensing and state laws, including insurance coverage regarding telehealth and teledentistry services. It is not uniform across this country, so always confirm with what is permitted, not just from a legislative side, but also from the insurance coverage side. Always selecting technology that's going to be both reliable and aligns with the needs of not just your patients, but the needs of your care team as well. Can you get clear images? Can you have, will you get pinged in a timely manner for when you're supposed to follow up with the patient? And then providing your patients and your providers an opportunity for feedback on the telehealth program to identify opportunities to improve that care and that system, and ensuring if there's additional changes to the workflow that need to happen.
McAllister, I'm just going to give you the 1-minute warning.
Well, it's perfect because I'm on my last slide. Thank you,
Okay,
Stacey.
Thank you.
So I know that's a lot of information. So just to summarize for everyone, we know that our veterans are facing greater disease burden compared to many of our non-veterans. The community care network and our providers that participate can help promote veteran oral health through an integrated care approach. And it helps connect our veterans with healthcare providers in their community and increase available points of access of care for them. And then finally, being able to leverage technologies such as telehealth services can really help enhance coordination of care and improve the health outcomes for our veteran population. And I got some resources here that we'll be sure that we share with everyone. That's the end of my section.
Thank you. Okay, so we have time for 2 quick questions that I'm going to pull from the chat. So the first is, who would be an example of a third-party administrator?
Yep, so Optum Health and TriWest, and then I forget under which one, but like United Healthcare, I believe falls under TriWest, and then have a long list, but those are the 2 big administrators, and their insurances underneath those 2. So Optum Health and TriWest are the 2 big ones.
Great. And then the next question is, how are referrals communicated to the third-party administrators? For example, email, fax, over the phone, etc.
There's a secure network that they use that I can see the abbreviation. I will put that in the chat for everyone in just a moment once I remember all the words for it, but there's a secure network that they utilize specifically for those referrals to the third-party administrators.
Great, thank you. And if there are other questions that folks have, please email us at programs@aidph.org, and we'll share that with McAllister or with Christine, or if we can answer that ourselves, and we'll get back to folks. So thank you, that was wonderful.
Thanks, I'll stop sharing right now.
Okay, so we're going to turn it over now to our AIDPH Executive Director, Annalise Cothran, who's going to introduce the next section, as well as our next presenter.
Yes, happy to do that. Thanks so much, Stacey. And thank you again, McAllister, for such an engaging presentation and ensuring that we have a really good foundation, setting us up for our applied interactive learning. So I appreciate that. So as a reminder, AIDPH and CareQuest have set up our VOHAC sessions to kind of do 2 things. One is provide foundational knowledge and information around concepts related to veteran oral health care, like the community care network. And then the second really integral piece of these sessions include applied interactive learning, which we know as adult learners is very helpful in helping us process information, ground information, and also apply it to our own personal daily work. And so that's really what we're doing here in the second part of this session, is identifying clinical solutions, stimulating opportunities to advance integrated and value-based care within our own respective organizations, understanding the intersection between complex healthcare systems, and the CCN is a great example of how 2 healthcare systems may interact, and then engaging in peer learning and interprofessional collaboration. So here's how this will work. First, you'll be assigned to a breakout room. Facilitators will guide the discussion. You will be given a Google form, which is essentially kind of a fancy worksheet to help you both apply information and get the information back in a personalized manner. And then we'll all come back together. And so I'd like to introduce Christine Cody, who will be taking us through the scenario attached to our applied knowledge session today. Dr. Cody has more than 10 years of dental experience. She holds a Bachelor of Science in Anthropology with honors from University of South Dakota, graduating Phi Beta Kappa. She attended the University of Iowa College of Dentistry and received the prestigious 4-year Dental Research Award. Dr. Cody also has experience as a Chief Dental Officer at a Detention Facility and as an assistant professor in the Department of Dental Public Health. Dr. Cody's passion is expanding access to care and providing person-centered care, which is a central part of KC Care's mission. And so with that, I will turn it over to you.
Hello all, thanks so much for having me, and thank you again, McAllister. That was an excellent presentation, so thanks. So I am here to give you a scenario. A veteran with periodontal disease has been referred to your practice from the VA. You work in an FQHC, and could you please describe the management of of severe periodontal disease? Tom has a history of smoking and diabetes, which complicates his dental care needs. And so with this, we're going to go through some different, I think Annalise has we're going to go through it step by step, how we would treat Tom, look at how we would utilize the resources that Tom would need, get additional information, also look at the continuity of care, basically just what would happen when Tom walks into our clinic and what we would hope to happen when we've done everything we need to do for Tom.
Excellent. Thank you, Christine.
And I think we'll go ahead and this will be posted in the chat as well too, because that is always extremely helpful when going through these. So this slide will be posted in the chat. So when we meet with our learning groups, we'll have all the access to all of the information.
Yes, thank you. They are currently in the chat, what you're seeing here. Liz has also added a link to the form. Again, the point of the form is to help design your conversation, save the critical elements, and then we, as the VOHAC team, also get information back about what you've learned, what was important, and also what we can do in future sessions to design content to be of the most help. And so with that, I believe that we are going to go into our breakout rooms. We'll be having 3 rooms, one being the main session and then 2 breakouts. So if you don't get an invitation for a breakout, that's because you're staying here in the main session. Otherwise, we'll go ahead and get into our learning groups.
Okay, everyone is still flying. And I want to share with this group, and Liz, perhaps you could announce this to the other room as well, that folks are going to have 10 minutes.
Thank you, Stacy.
I'm not sure if we said that.
Oh, I'm
So,
sorry, Liz, did you say you were going to do it? I missed.
You can do it, Annalise. That's fine. I'm happy either way.
okay, great. So it's wonderful to see everyone. And as Annalise shared, we are going to be talking about the case that Christine just presented to us. If possible, we're going to ask everyone to put their cameras on. We always find that the folks who have their cameras on often tend to be the only folks who talk on the call. So the more people who have their cameras on, we're hoping the more people who will speak. But we're still going to call on you if your camera's not on. So don't think that you're out. So please copy the link that's in the chat, the Google form, and that will let you type in your own answers to the questions as we're going through it. As Annalise said, that'll help us save the information to get a sense of where you all are at with your learning. It'll help to inform future sessions, and you'll also get a copy of your survey, your form emailed to you. So you can have that as well and use that to complement your continued learning along with the slides. So given the case of Tom, the first question is, how can the dentist at the FQHC effectively coordinate with the VA to access Tom's medical history and understand his specific oral health needs?
Can they ask for a copy of that referral?
You said to ask for the copy of the referral?
Yeah.
Yep, sounds like a great place to start.
I mean, I'd also confirm with the veteran as well, go over their health history with them. And hopefully they would have sent over the coordinating documentation to either validate or update or see if that's accurate or not.
That's great. Other thoughts?
Stacy, it's Donna.
Hi, Donna.
If they're in that community care network, there should be some availability for information sharing as far as medical records, right? So they could just request what kind of care he's undergoing or make sure he's current with his care.
Great, thanks for that. McAllister, is there anything you would add there as well?
Think besides the coordinating with the medical provider too, I think is really important. I'm wondering if there's any other additional documentation from, since these, depending on how, if he's received services for dental through the community care network before, is there other information about previous dental treatment that he's received as well that maybe the VA healthcare system has access to?
Good suggestion.
McAllister, are you specifically referring to like chart notes, health history, all of that? Because I'm, in my mind, we would need everything before we could even start.
It would definitely be helpful to have that. At minimum, I like to know, did you have like periodontal treatment before? And if so, do you know where it was done? But definitely having all those other components too gives you a much more complete picture. Yeah.
Okay, so the next question, what strategies can the FQHC implement to address the challenges posed by Tom's diabetes and his smoking history while treating his periodontal disease?
I can start, Donna. Our FQHC offers a diabetes support program, and it also offers smoking cessation classes. So a clinician could be sure to offer those services to the patient.
Great, so that would be like an internal referral process to programs that are offered. That's great.
I was thinking if your organization had a traditional health worker, that might be a bridge between Tom and maybe the FQHC to definitely education for that would be important, kind of like what Donna said.
Yeah, I'm curious if anyone knows how common is it for FQHCs to have programs like that?
In rural West Virginia, it's very common. I can't speak for other places, but those programs are fairly readily available here.
Yeah, that makes sense. That it would be.
Oh,
Go
sorry,
ahead.
Stacy. I was just going to say in Oregon, because we have the coordinated care organizations, we support the FQHCs with that type of education because we specifically employ tobacco cessation coordinator. We have a whole team that works on diabetes. So, the FQHC oftentimes doesn't have the funding for some of that. So we support them with that, with classes.
Great. Are folks aware of what's offered at FQHCs in their own communities? Other people on the line, on the screen?
No, but another thing that I would mention, Stacy, would be making sure that the patient is monitoring his diabetes while going through periodontal treatment, because a lot of times the condition will improve the status of the diabetes as we improve the oral health.
Yeah.
I would just like to add, as someone who has worked in a couple different FQHCs, sometimes I'm not even aware of all the services that my FQHC has, and it can be, depending on how the onboarding process was and how communications within your FQHC, that can be challenging too. So internally too, making sure that your teams are aware of the services that you are able to provide is really important, because I've been in a really big one, I've been in a really small one.
Thanks, McAllister. Okay, next question. In what ways can the FQHC ensure continuity of care for Tom's periodontal disease management, considering he might require ongoing treatment and monitoring?
I'll just hop in as everyone's thinking too, especially if we're thinking about needing to work through the community care network. That means you're going to have to be able to do some continuing coordination with maybe their primary care or whoever first referred them, because the network might not necessarily realize or even approve right out the bat this need for, unlike a cavity where we talk about, well, you take the decay out, we fill it, the cavity is gone. Periodontal disease is ongoing in different ways. I would argue decay also is an ongoing disease, but that's a different conversation. But there are some standards when it comes to, well, you're going to need to come back every 3 to 4 months for your periodontal maintenance, and being able to make sure that you have those appointments scheduled too, and that coverage is going to be happening for our patients. So there's going to be some more conversations that need to happen, not just with the patient, but who's responsible for covering the care and paying for the care for that patient too.
And it would really depend on why they were referred to the FQHC. If it was because they didn't have a periodontist, then their episode of care would only be for those services related to periodontal disease, and then send back, because they, the hygienist and the dentist should be able to follow up on their post-care and get them on a more routine maintenance. So I think it depends on why they were sent out to the community.
Great point. And then our final question in our last minute or so: how can the FQHC collaborate with Tom's primary care physician in the VA to ensure coordinated care for his overall health and dental needs?
A shared EHR would be wonderful if we had such a thing. Some states do, we in Oregon do not.
Can I ask a question? And maybe this, as folks are thinking about this, but does anyone know, when you're in the VA system for healthcare, do you typically have one primary care provider that's assigned to you that you see on a regular basis, or does that vary? I'm thinking about in terms of developing that relationship and familiarity with your case.
It's typically one primary care provider for the veteran, that even if they go to another state, or like they live in Oregon, but then they vacation, in the cold winter months in Texas, they still have one primary care provider that coordinates their care.
Okay.
Yeah.
That's helpful to know. Thank you.
So then it might be helpful for the dental office to communicate with the primary care physician over a patient if necessary, to make sure that they're aware of the care that's being done.
Right. Yeah. And then that also brings up, I think, connecting to the comment earlier about following, tracking your diabetes management over time, and having the primary care provider be involved in that process, or at least be aware of how that's changing. Thanks, everyone. Turning it back over to Annalise.
Thanks, Stacy. So I was gonna share my screen, but really the screen that I was gonna share is just a slide that says report out. And in the interest of wanting to see folks and hear from everybody, I will not share the slide, and instead we'll just verbally say, we'd love to hear from both groups, just an encapsulation of how your discussion went, and maybe some of the highlights of what you captured in your interactive applied learning session. So I will leave it open, and we'll give about 3 to 5 minutes here to share insights.
Hi, Annalise. This is Wei-Sam speaking. I helped facilitate our group discussion and was also nominated to also report out on our discussion points. We had a lot of good discussion about really the technical aspects of making sure that that Tom could get the care he needed. That's involved communicating between the primary care provider, the FQHC, utilizing the staff members such as any care coordinators, community care workers, etc. And also like the logistics of motivational interviewing, speaking to Tom as if he's a person and seeing like what motivates him, what could propel him to want to improve his own health. And what that also involves technical aspects such as scheduling. What does your schedule look like? And even through something as small as scheduling, you can learn a lot about a person, like what does he do in his free time, etc. And so, yeah.
Oh, I love that, Waysam. So it seems like your group really took a very holistic approach to considering this very comprehensive disease management process, which I know FQHCs are pretty uniquely qualified to take that very whole person comprehensive care approach.
Yeah, we definitely elevated the fact that oral health isn't isolated from the rest of the body, and FQHCs are in a unique position to promote that.
I love that. Thank you for that contribution. So my group, the group I was in, I don't know if I'm going to take ownership of it. Let's say the second group. We had a really fruitful discussion too, and we didn't choose someone, but it makes me think that maybe I could just call on McAllister, who's already presented today and can give us some kernels of insights that we discussed during our applied session. McAllister, do you mind sharing a little bit?
Definitely. So some things we talked about in our group was making sure that we had as much information as we possibly could get. So opportunities of if that patient had received, say, periodontal care before, where was that, for how long ago, what was going on with that, being able to also understand why that patient had been referred to the FQHC as well. So thinking about, is it because they needed a periodontist specifically? Is it because there's just no dental care within the VA healthcare system? Because understanding why that referral got in is going to also help us better understand how we want to coordinate continued care. With periodontal disease, we know that there's recall schedules patients have to be on. They have to be on particular maintenance for good long-term success with that. So understanding why they ended up at the FQHC to begin with, and then how are we going to be able to continue to support their care moving forward? And it's not just a single instance event. One thing that I believe Laura brought up was being able to, and this is not true in every state, but having a shared electronic health record that we can all access and be able to get through would be so helpful in not just coordination of care, but being able to understand our patients' needs and helping them understand their needs and really just support that more integrated approach. So there's some places where we do have shared EHRs, but even maybe advocating for that more often can really help support the health of our communities as well.
Yeah, so our group really seemed to focus on the infrastructure pieces and how processes could really help expedite the coordination of care. And it makes me think that really the combination of the two groups, like we kind of solved the problem, right? So just thinking about holistically from a treatment perspective, how we can really be comprehensive in our patient care delivery approach, and then match that with an infrastructure that's really conducive to ensuring that the veteran has effective continuity of care, can really stimulate that integrated care approach and really couched in a value-based design. So I want to thank everybody for that discussion, and I'm going to go ahead and project our last few slides and close us out for today. I appreciate everyone's attention, and while we still have your attention, we want to make sure that we are bringing some legislative awareness to you. As we're talking about veteran oral health, AIDPH has been working in collaboration with CareQuest and other national partners to help with bringing awareness to a variety of different topics, including here, expanding access to dental care through the VA. So as McAllister shared in the very beginning, 85% of veterans cannot access dental care through the VA because of strict eligibility criteria. So when we're talking about the community care network, we're talking about the 15% of veterans who are eligible for dental care and being able to source that. So eligibility at the federal level, bills that are at the federal level. One is a full expansion of benefits to veterans, and that is offered by Congresswoman Brownlee. But there are two pilot programs that very closely align with what AIDPH and CareQuest are promoting here through this Veteran Oral Health Action Collaborative, and that there are pilot programs being designed through the VA to expand access to care for veterans with diabetes and heart disease. So, and there's another bill offered by Senator Tester to increase access and expand the workforce for dental care, essentially. So we wanted to call attention to that, and also specifically mention that Open, one of our partner organizations, is having a virtual Hill Day in the fall. So if you would like to bring awareness around this to your decision makers and your legislators, there's certainly an opportunity to do that through the Open Hill Day, and we'll drop registration for that into the chat. And so next steps for our collaborative and the session, one is that bringing attention to this monthly opportunity. And so you'll be able to visit again in August to learn more about community partnerships for data collection, followed by the role of data in advancing integrated value-based care and oral health for September. So you can go to the AIDPH website and register for those sessions coming up. Again, this is structured so that it's didactic plus interactive and personalized learning. So we hope that you'll find value in both of those sessions. If you'd like to earn CEUs for today, again, in the chat, and we'll send it out in the follow-up, that you can request continuing education sessions, and also calling attention to our certificate. AIDPH also offers certificates for other educational learning collaboratives like our Rural Oral Health Echo program. And so if you would like to show specialty and knowledge and expertise in having participated in these sessions, you can certainly do that using our competency quiz, and then through our self-guided program, apply for a certificate in veteran oral health. So we appreciate your attention today. Appreciate our partners at CareQuest Institute for Oral Health, and we will end the session. We hope to see you again in August.
There's a hand raised. Anne, did
I
you
have a quick question. If a
Oh,
patient,
yes.
on that flow chart for patient reimbursement, if a patient needs quadrant root planing or 3-month recalls, is it hard to get that filled out every time and get the money back? Or is that an easy process? It looked like a lot of steps. And would they go through with all of it?
Yeah, and if it's okay with you, I'd really like to connect you to McAllister directly. McAllister, would that be okay? Just given the time that we have left. And it sounds like that's something that McAllister could probably help you with via email, if that works.
Thank you.
That sounds good. Thank you.
Okay, perfect. We'll make sure to do that. All right. Thank you all for your time today. We'll see you in August.
Thank you.
All right.
Thank
Bye-bye.
you.